Okay, I think we can start now. So good afternoon, everybody. Welcome to this EANS webinar on laser interstitial thermal therapy, a transformative, minimally invasive technique that is gaining momentum in various neurological applications. Today, our focus will be on epilepsy surgery. My name is Alexandre Campos, an epilepsy neurosurgeon from Hospital Santa Maria in Lisbon, Portugal, and I'm delighted to co-host today's sessions alongside my colleagues, Olaf Schins from Maastricht University Medical Center and Tom Theys from University Hospitals Leuven. We are thrilled to have you all here for what promises to be an engaging and informative afternoon. Today's program features three outstanding experts in the field, each offering unique insights into the current and emerging uses of LITT. Professor Daniel Curry, Professor John Duncan, and Professor Carl Russler will guide us over the next hour from hypothalamic hamartomas over temporal lobe epilepsy to future applications and perspectives of LITT. Following the presentations, there will be a brief discussion session. Throughout the webinar, we encourage all participants to share your questions and comments in the Q&A box at any time. We will be monitoring it closely and bringing your questions into the Q&A segments following each talk. We are excited about the knowledge and discussions that we are unfold this afternoon, and we hope you find the session both engaging and valuable. We will start now with Professor Daniel Curry, a renowned pediatric neurosurgeon from Texas University Hospital in Houston. Dr. Curry is widely recognized for his groundbreaking work with minimally invasive approaches to epilepsy. Today, he will discuss hypothalamic hamartomas, an area where he probably has the largest published series. This is a rare but challenging condition where LITT has shown impressive outcomes. So please go ahead, Professor Curry.
Sorry, I couldn't find the controls. Good evening, morning, afternoon, wherever you are. And I'd like to thank the organizers for the invitation to speak about a topic it's dear to my heart, and I have put a lot of work into over the years. I'm going to go over the application of LITT and hypothalamic hamartoma. The disclosure-wise, I am still a consultant to ClearPoint, which I'll mention during this talk. I'm going to talk about a lot of technologies. I'm not going to advocate any exclusive uses. My objectives is to have the listener understand what the advantages of LITT are in hypothalamic hamartoma and what the risks are. Generally, hypothalamic hamartoma is a rest of cells sitting near the hypothalamus, histologically normal, but in the wrong place, that create seizures of a very particular and peculiar variety in the gelastic seizures. They also have a high tendency to progress into epileptic encephalopathy in children. They also have some precocious puberty and occasionally some rage attacks and other psychological aspects of it. The diagnosis is frequently delayed because nobody thinks laughter is a problem, and the high seizure burden is really an issue. They are notoriously resistant to medicine, so this is essentially a surgical problem. There's been many efforts over the years to approach this, and there's classification scores that people have used planning on their particular technique with the Delalan disconnection or resection approach and the Régis stereotactic approach. I mainly look at the Régis stereotactic approach in hypothalamic or in laser ablation, as it can sometimes help us guide some of the approaches and the indications. Generally, our goal is to cure, of course, but when we can't, palliation of epileptic encephalopathy is very important. About half the time, we can reduce the rage attacks, and of course, complication avoidance is the big deal here because the open approaches have a notorious record of complications. So why laser NHH? Because it's a deep lesion, we know it's epileptic, so we don't have to do any other diagnostics, and we know it is severe. It's a minimally invasive approach, and it avoids the access-related morbidity of the open operations. It has a minimal stay in the hospital, and it's thermal treatment, so it's an immediate effect as opposed to a delayed one, say in radiosurgery. And why LITT instead of other thermal ablations? Well, it's MR compatible components. And that's very important because it's this near real-time MR thermography that can really allow us to dose this treatment accurately and precisely. So it's really a truly MR guided approach as opposed to an MR planned in the RF series. So we're trying to disconnect mainly in this operation, but if we have to, or if it has to happen, we can attempt to completely destroy the lesion. We've gone to staged surgeries here for a reason I'll mention. And as I looked at my staged series, we saw that if we got about 60% of them on the first try, they're in the pretty good outcome category. We just don't know which 57% is the important one, but we are trying to disconnect first. MR thermogram, as I mentioned, is a very important tool here. It's focusing on the chemical shift of proton resonance frequency here. The concept is we can see temperature change, not necessarily the temperature itself, but the temperature change, and that's the important thing. It can be a little prone to drift. So when you're applying an MR thermogram, conditions that minimize the drift are important, and any other diffusion imaging can cause a little bit of an erratic signal. So something to keep in mind. We published our first series of this in 2012. There was 2 HHs in the first series of ablation for epilepsy in general. And then we had a small series published in 2013, kind of honing our indications. Our largest series, though, is 71 patients published, showing about a 93% efficacy rate, which is an astounding number of the gelastic seizures. That was the focus of the approach, is to see what's the percentage of reducing the gelastics. But we did notice that about a quarter of them needed more than one session, some needing 3. So this iterative approach, as opposed to the one good surgery thinking that a lot of us were trained on, this iterative approach seems to be the way of maximizing the efficiency and minimizing the complications. There are other series published, however, that aren't quite as rosy of a picture when it comes to the complications. This one by Zhu had the efficacy in the same range, but had a near 40% adverse event rate. So there is some heterogeneity in the complication profile of this tool. A couple of other papers out there, since the number, each of the series is pretty low in its N, trying to use meta-analysis to reach a conclusion. Alexander Weil did a paper a few years ago that looked at this, relatively inconclusive on saying that LITT was the ideal tool or the most superior tool in the surgical treatment of hypothalamic hamartoma. But Konstantin Slavin's paper clearly showed with meta-analysis that it was superior to RF. So what are we trying to do? We start with preoperative imaging, high resolution T2. Sometimes I need to do a stir for the poorly myelinated kids. And sometimes on the post-ops or the re-ops, flare scan can show me more lesion. And then you put the fiber in and whatever tool you feel is going to be best in your hands. We are very much into rigid stereotaxy. And a lot of these tools are, stuck with their own programming software. So you're kind of stuck to some of those systems like ClearPoint or Rosa, but I'll show later on the talk which ones I prefer and when. There's 3 main lasers available to us in the US. I'm not sure all of these are available in Europe, but the Medtronic one is the most common one. It's the Visualize system, actually born in Texas. That's how I got involved with it, but got absorbed by Medtronic years ago. Monteris is a bigger system, and I'll go over a third in a sec. There are some important differences. One is saline cooled, one is gas cooled. The laser wavelength in Visualize is faster, but the probe in Monteris is larger and there's less safety markers to choose from. But picking the probe is very important. Picking the diffuser tip is very important. We use the 3 in a hypothalamic hamartoma because there's a lot of real estate to worry about, as opposed to a 10 millimeter where you really can't see what's going on in the other planes. And every plane is important in hypothalamic surgery. So we use that little 3 millimeter diffuser tip. ClearPoint has made a laser where we've tested it a few times. I haven't applied it to hypothalamic hamartoma, but it gives us 3 diffuser tips. And it's a little bit low powered. It's the same frequency as the Monteris, but it is yet to be tested in the hypothalamic world. So this is what we actually see during the operation. We split the anatomic scans on the left to the thermogram on the right, and we watch the lesion develop. This is an irreversible damage map handled by the software that tells us a certain pixel over a certain time is now destroyed, and I simply paint the lesion to its maximal with that thermogram. So that's the thermogram dosing that you can't do in RF. This is what it looks like. Here's the probe inside the lesion. Here's the irreversible damage map, and now it's infused and enhancing where it didn't before. Clearly, there's complications in the hypothalamic hamartoma and the hypothalamus region we got to worry about. The most important, which is a memory circuitry. There's obesity to worry about, getting too far into the hypothalamus, and then there's the pituitary stalk we have to worry about for DI, which is a big problem in the open operations, or salt wasting in the children. We've had in our series of about 195 hypothalamic hamartomas ablated in this way. We've had 3 memory problems, only one of which was a permanent problem, 1 transient DI, 1 hypothalamic obesity child, and then there's this series of kids that have a transient sodium problem. They're mainly the babies where you're ablating the large volume of the giant hypothalamic hamartoma. So also in that scenario, in that series, there's a couple of cranial nerve 3 problems because it gets hidden in that lesion. This is the memory problem that was published by NYU. I stayed out of the publication to stay as objective as possible. And basically what happened is both of the mammillary bodies were injured, and we stopped our program to look at the data that supported that safety marker radius and realized it was an average. And so we gave it a little bit more room. We gave it 2 millimeters now in the direction of the heat. And this problem is pretty much minimized. We've had some endocrine problems, 1 transient DI. I'd say 1 patient clearly had a hypothalamic obesity syndrome from an involvement in the ventral median nucleus of the hypothalamus, and a few thyroids, but otherwise, endocrinologically, they do pretty well. The weight gain problem is obscured by the use of high-dose perioperative steroids. And we use this because edema in your hypothalamus is a bad thing. They have lots of fluctuating mentation problems. So when we did our first, we had those problems. We did this steroid protocol, and now it's the vast majority of these patients go home the next day. They don't have that problem anymore, but they do have some weight gain issues, but it's temporary. It's gone by about a month and a half. So in our considerations of planning this for patients, we want to look at the seizure burden of the patient, the age, the trajectory to epileptic encephalopathy, what their intellectual ability is now, or the skill maturity that can influence the stereotactic accuracy and its operative history. So patient selection is very important. The young kids, especially with a high seizure burden, they're headed for the encephalopathy. Clearly, that's a laser candidate, but there's room for pause. On the older kids, a smaller lesion, they're intellectually normal. Maybe you need to opt for something less damaging like radiosurgery, and you have some time to wait on it. So, but usually use the best tool you can if you cannot refer out. This is an example of one of those that I did not opt to do with a laser because it's very, very close to the memory circuitry of a normal boy. And of course, recurrence is not unheard of at all. If it's a dacrystic or a gelastic semiology, we look for any residual hypothalamic hamartoma and go after it. If it's not, we'll do a stereoG a year after to look for the other sources of gelastics, which could be cingulate or mesial temporal. Reoperation, we've done it for opens, done it for ablation failures, we've done it for radiosurgery failures. No increase in the morbidity because it's just a corridor. So lessons learned, we've gone to this iterative plan, and we think that's the safest approach. We've learned a lot about heat sinks, and we target our heat very close to it. If it's multiple lasers, I use a robot to put the lasers in. If it's a single, and if it's small, I'll use the ClearPoint system. I use a very judicious application of these low limit markers, which automatically turn off the laser, and I put it 2 millimeters away from any of the structures I'm trying to preserve in the direction of the heat. Learn that 2 millimeters from that complication case that I pointed out. Thermogram drift is an issue, so you have to put a marker in and monitor it and reset your phase a lot. And then when you're inaccurate, just abort. Come back another day. This is a catheter in the wrong place. We just aborted it, put it in the right place, and the kid's still cured. We were taught not to do transventricular approaches as a resident. I think that's the optimal way of doing this often. So we've gone to that. And we've learned a lot about heat sinks. This is an example of the laser too near the bottom of this cooled from above and below hypothalamic hamartoma. You move it by 2 millimeters and it starts to ablate. Sometimes previous surgery or even previous ablations can create heat sinks. This is a little island of cooled tissue above and below. Here's a very extreme example of this. This is a complication I got from another center, and it made this little isthmus of tissue that was still active. So I had to put the laser, pointed out by this arrow, right in the isthmus of there, trying to stay away from the heat sinks. And we were able to successfully ablate it, at least by the irreversible damage map confirmed by the infused scan. And so the child is finally treated. But those post-ablation issues can be a problem. Here's an isthmus that's born that way. This is 3 sides of cooled hypothalamic hamartoma. So you have to find the worst one and put the laser right at the tip. And here's the ablation of that laser, or of that isthmus of the hypothalamic hamartoma. Also, sometimes it's too small. Sometimes your target is too small to get a lethal temperature in the hamartoma and yet leave the surrounding structures intact. That's about 3 millimeters, but it depends on the heat sinks. So what I've done in the past, I just try it. You know, I put the laser in, I get as close to the heat sink as I can. And if it keeps clipping off, then I know I can't get that thermal differential that's going to be therapeutic, and radiosurgery is then the alternative. Giant hamartomas are a special case. Their preoperative morbidity is high. They have a relatively higher operative morbidity in laser, but certainly nothing near the open. They've had a total of 7 salt wasting kids. 6 required readmission for a supplementation of 3%. And the optimum disconnection strategy on this patient is unknown. There is work in the hypothalamic hamartoma community that still says that this is an open operation. I disagree. I still think you can do it with lasers, but you have to do it with a lot of lasers. And that's not always an easy or inexpensive thing to do in other centers. This is the example of a multiple laser ablation. I'm pretty much having to destroy the whole thing because I don't really know where the connection is on these little babies with giants. And this is a video of that end of it. Here's the infused scan on the left and the T2 scan on the right. Surprisingly, amount of edema is very well tolerated. They're totally untouched by this approach, and we can get to the most of it. I have specifically avoided the interpeduncular cistern on these children because the third nerve can hide there. And that has been a problem on these giant ones and on the type 4, the Rigid type 4s. The third nerve is in the way, so I would definitely do as much imaging as you can to find it. I have not been good at finding it. So I've had a few. So in conclusion, HH surgery can be tailored to the presentation of the patient, especially on the young patients that are headed for an epileptic encephalopathy. LITT is well suited for surgery in the hypothalamus. It avoids this corridor-related morbidity that the open surgery was replete with. 50% was the complication right there. The judicious use of the low-limit markers is a very important thing, getting it close to the structures to preserve, but not too close, so that the error in the irreversible damage map doesn't injure that circuit, especially the mammillary bodies, the fornix, and the mammillothalamic tracts. So LITT has really reduced the morbidity involved in HH, and it has increased the efficacy, but I think we can do better. There's a combination of techniques that always can be employed. Generally, we thermally ablate as much as possible, and if there's any of the residuals that I can't get a thermal differential on, I'll consider radiosurgery. And of course, you know, this is still a destructive approach in the hypothalamus. So less destructive approaches, maybe focused ultrasound, maybe neuroaugmentation, maybe pharmacologic approaches, and intrathecal antiepileptics or gene therapies are needed to minimize the risks that we are taking in this operation. And with that, I thank you for your attention.
Well, thank you very much. Wonderful talk. You answered many questions that I had, but I still have many doubts, of course. When we are doing our planning, it's always difficult to sometimes we have difficulties avoiding the structures that we know that we should preserve, like mammillary bodies. it's not infrequent to see the mammillary bodies involved in the hamartoma. So, and sometimes it's even very difficult to see where the mammillary bodies are inside of the hamartoma. So, what is your strategy to? And if you do you sometimes opt just to eradicate one of the mammillary bodies, so not putting some markers, to safety markers on one mammillary body because you know that it's already destroyed by the hamartoma, or you try always to preserve both mammillary bodies?
Well, I would say that the times that I cannot find the circuitry, the fornix going into the mammillary body and the mammillary tract coming out as posterior medial edge, is rare. Usually it's a problem of imaging. So it's usually a high resolution 1 millimeter or 2 millimeter cuts on the T2 can give us that clarity. And when I have that sort of anatomy, then I'll plan accordingly. I have not knowingly sacrificed one memory circuit or the other, but I'm sure there are some of those really complex lesions where we really can't see the columns of the fornix going through the lesion. The resolution just isn't there.
But if you see the hamartoma around the one of the fornices, what do you disconnect actually? You disconnect outside of the fornix, or do you?
Usually we have a
this?
decent amount of columns of the fornix going through the hypothalamus, which is stretched and kind of compressed. So if I window radically, I can see that little 1 millimeter separation of tissue where the hypothalamus is smashed but still contains the column of the fornix, and there's the line of the lesion. And it takes a lot of windowing, and
yeah,
I'll do that, and I'll ablate up to that border when I can.
Okay. We have some questions from the Q&A box. What is your safety marker temperature? And if you have a feeling that the hamartoma tissue is melting easier than the other tissues, from Yugoslav Ivanovic.
Yeah, the first question, I dropped my thermal low limit marker to 48. So 48 degrees, it'll stop here. It comes out of the programming as 43. I don't think you can get anything done with 43, but 48 with the turnaround cutoff. So these are, if you're using 2 planes, you have about a 6-second refresh rate on the thermogram. 6 seconds at 48 is usually not going to be a problem. Now, if you go to a 3 plane and now it's 10 seconds, you may want to drop it to 46. Gives us a little bit more room to avoid thermal injury. I have not found that HH tissue ablates any faster than anything else. It doesn't seem to take up heat any more or less.
Okay. The other question is, in these giant lesions, do you plan several sessions, or you just try to do it in one session? I know that you have a paper with a staged ablation, but do you plan ahead to do this staged, or you just have to do it if the children stays with seizures, keeps seizures?
I would prefer staged physiologically, but there are practical matters and financial matters that prevent me from stretching it out over months. So my approach to those that can't afford to travel that long or all that is to do as much as possible in one session. And I showed you those videos of that. That's been my approach. Recently, we haven't had a big issue with that at all. We had that one cranial nerve problem I mentioned, and then a couple of salt wasting scenarios, but generally very benign compared to the open approaches of these kids. It used to be 3 weeks in the ICU and a sodium rodeo, and it was a mess.
Okay. Just a last question about steroids, because you do it 1 week before you start steroids.
Yeah.
And are you so you still doing this protocol with 1 week before doing steroids, and you believe it's important to do it like this?
I'm still doing it for hypothalamic hamartoma. There was a paper out by Tandon, my neighbor up to the north, just up the street, who said you don't have to do it for others, and that's fine. But HH, hypothalamic hamartoma, is so close to all the circuitry, I really would recommend it. The morbidity of the edema of the first few was striking as far as the change. It all went away. It's just a very striking change in the mentation if you don't do it. So yes, I would, and I do it a week prior. Basically, you know, it's borrowing the old GBM steroid protocols that used to tighten up the blood-brain barrier a week prior to the operation. It worked very, very, very well, so I've kept it.
Okay.
I also have one question, Alexander, when I'm allowed.
Yeah, please.
So there is just a publication in the ACTA from the Rocamora group in Barcelona. They described an adult population treated by MRI-guided LITT, and also the hypothalamic hamartoma group. They had exactly the same conclusion as you have for their adults, so 85% seizure-free outcome, but for the gelastic seizures. For the other seizures, they reported 28%. So my question to you would be, how is your preoperative counseling to the parents of these children? What do you say? This is a palliative procedure or is a curative procedure? Because you can cure the gelastic seizures, but not the others. So how do you deal with this counseling?
I tell them exactly what you just told me. I said we're focusing on the gelastics. If you go early enough, you may not have had secondary epileptogenesis, which is the bane of the adults that have had the hamartoma driving seizures through their brain their whole time. And I think that's one of the reasons why the total seizure freedom rate in the adult world is so poor, is all the secondary epileptogenesis that has to be chased afterwards. So I think in kids, we have a better chance. But I definitely keep the options open for secondary epileptogenesis and having to go after it. I've gone after a few of those, and I've learned my lesson over the years. Any gelastic seizure, it's just almost never in the cortex. I've done a number of kids with stereo G failure, and it's almost always the HH, even when you can't prove it by stereo EEG. And that's the frustrating thing about subcortical epilepsy, is it's not as clear on the stereos as it is on the cortex would be. So if you do have a cortical source, you can see it. But if you don't, you're not sure. Going after the HH always gets rid of the gelastic seizures. But you're right, they're a note of caution. It's a very difficult syndrome. And if it drives seizures into other areas of the brain, there's going to be another approach to that.
Okay. Last question just dropped in. So what are the nuances of planning in review procedures from Chirag Solanki? So I guess this is a complicated answer, but I ask you to be short on the answer, please.
So protect your structures 2 millimeters away from the heat, 2 millimeters off of the structure to preserve in the direction of the heat source. That's the most important aspect of this operation. Know where your heat source, your heat sinks are, at least get a good idea of it, and plan the heat source closer to the heat sink. So if there's a surface with pulsatile fluid, get closer. I use a rule of 2/3. If I'm in the middle of the hamartoma, I'll move it to 1/3 closer to the heat sink, usually the surface of pulsatile CSF.
Okay, great. So next, we will hear from Professor John Duncan, consultant neurologist at the National Hospital of Neurology and Neurosurgery in London, a leading voice in epilepsy surgery. Professor Duncan will talk about the role of LITT in treating temporal lobe epilepsy, sharing insights from both clinical outcomes and real-world experience. Thank you, Professor. Please, your audio is off. We can't hear you. Okay.
Okay. I just need to reconfigure the desktop. Can you see that now?
Not yet.
Okay. Okay. Sorry. I have to reshare. You have that now?
Not yet.
Okay. Is it possible that the previous speaker is still sharing, so I can't share?
I don't think so.
No one is sharing. So
You can't enable multiple shares, maybe?
I will. It's done. Please try again.
For a reason Okay. The problem is that
Did you click the green button?
yeah, absolutely.
Yes, of course. Okay.
So I'm pressing share, but it's not the presentation is not coming up for you. I'm not certain why it's not sharing, must say. Maybe I need to come out and come in again. Shall I do that?
Please, I think it's a good idea.
Yep.
Oh,
Okay, let's try
okay.
again.
You're back. So
Yeah, that's better.
we'll try again. If it doesn't work, maybe we can change and Professor also. Okay, it's
yeah.
working.
Let me
Start
just get this to the full,
working.
just get me to the full
Okay,
screen.
wonderful. Thank you.
How's that?
Perfect.
Wonderful.
You
Perfect.
can see and hear. Perfect. Right. Well, thank you for the opportunity to talk with you about laser interstitial thermal therapy for temporal lobe epilepsy. As a disclaimer, as mentioned, I'm a neurologist, not a neurosurgeon or a neuroradiologist, but my particular interest is in image-guided surgery for epilepsy. I only have disclosures of academic grants. I want to discuss with you in these next few minutes the place of LITT as an alternative for anterior temporal lobe resection for drug-resistant TLE, and also the issue, less common but important, of the use of LITT for neocortical TLE. Now, the standard treatment, of course, has been the anterior temporal lobe resection with removal of the temporal pole, variable amounts of lateral neocortex, amygdala, hippocampal head and body. And we've seen more selective approaches, the selective amygdala hippocampectomy and the transsylvian approach. In general, we expect for 60 to 70% of patients to be seizure-free at 12 months, and we expect some attrition over subsequent years. So if we follow people 20 years out, about 40% have remained entirely seizure-free forever and in a day. A standard craniotomy, at least in our hospital, would involve 4 days in the hospital and about 2 months recovery before somebody will get back to their previous occupations. After dominant, language dominant temporal lobe resection, 30 to 50% of individuals will have significant difficulty with word finding, and a further 40 to 50% a clinically significant verbal memory decline, with less impact on a non-speech dominant temporal lobe resection. Now, as we were hearing from Professor Curry earlier, LITT allows precise trajectories with catheters of 1.6 to 2.2 millimeter diameter and the use of MR thermography to guide the area that is heating. And we're looking to ablate brain tissue with a heating of 50 to 90 degrees from the targeted laser light. As we heard, there were essentially the visual aids and the neuroblate systems, with the laser being emitted from the distal 3 to 15 millimeters of the catheter, and typically resulting in an ovoid 10 to 15 millimeter diameter ablation volume. And of course, if one wants to make a linear ablation, the catheter can be retracted and the ablation can be repeated. For treating hippocampal sclerosis, we need to have precise trajectories and can model the laser burn zone. Typically, there'll be entry to treat hippocampal sclerosis, entry at the junction of the inferior middle occipital and the middle temporal gyri, avoiding the sulci to minimize the risk of vascular damage from the trajectory, with the aim to ablate the hippocampal head and the amygdala with an ablation volume of the order of 3,000 cubic millimeters and sparing the posterior hippocampus. There's two reasons for this. Firstly, and then pragmatically, the trajectory coming from the junction of the occipital and temporal gyri will inevitably miss. It won't target the posterior hippocampus. And secondly, we know from neuropsych studies that if the posterior 45% of the hippocampus is damaged either surgically or with any other modality, that memory will have a much bigger hit taken to it. Now, so far as the amygdala goes, again, a bit of precision is needed here, because we know from conventional surgical studies that if the temporal portion of the piriform cortex is removed, the chances of being seizure-free are 16 times higher than if the piriform cortex is left in situ. So in terms of getting our trajectories, we can evaluate the structures that are ablated and model this. And I think essentially the main difference from conventional surgery is that one avoids damage to parahippocampal, fusiform gyri, and the critical white matter connections, the IFOF, or inferior fronto-occipital fasciculus, the arcuate, and the middle and inferior longitudinal fasciculi. In terms of the outcome, typically for hippocampal sclerosis, the hospital stay would be 24 hours. There's no craniotomy, so there's much less risk of infection. Typically, patients will be back to work within a week rather than 2 months, 1 to 2 months. Seizure freedom rate is less good, about 36 to 70% at 12 months. And the neuropsych deficit, certainly less impact on cognition, with, for example, in one series, significant reduction of verbal and visual memory in 10%, and significant decline of naming skills in 13%. So, should we now regard LITT as first-line therapy for hippocampal sclerosis? I think it's clear, or it's emerging, that there is lower chance of complete seizure freedom than after anterior temporal lobe resection, but there's less neuropsychological deficit. With current straight line or line of sight catheters, it's very difficult to ablate the piriform cortex with a single catheter. And I think a work in progress is to use 2 catheter solutions to enable ablation of the piriform cortex in the medial amygdala and the anterior 50% of the hippocampus. The question of whether open resection can be carried out if LITT fails, my neurosurgical colleagues tell me that, of course, this is possible, but actually it's technically more difficult, and there's a higher risk because of adhesions in the pia and of scarring, and the risk of complications is higher following anterior temporal lobe resection if there has been a previous LITT. Okay, let me now just mention to you the possible role of LITT for neocortical temporal lobe epilepsy, and I can probably best illustrate this with a case. A patient is a 23-year-old lady. She's a young lawyer. She has bilateral auditory and visual auras and abdominal auras. These progressed automotor seizures with loss of awareness at a frequency of about 10 per month, and evolution to focal to bilateral tonic-clonic seizures approximately once per year. On video, we see automotor seizures with loss of awareness, head and eye turning to the left, hand automatisms, swallowing, fiddling, some retention of awareness, and ictal speech. Ictal EEG showed a buildup of rhythmic slow in the right posterior quadrant with rapid propagation, including to the left, with the most prominent rhythmic activity over the right temporal region. And MRI normal, even in retrospect, is unremarkable. FDG PET analyzed with SPM on a voxel by voxel basis, however, showed hypometabolism in the right posterior medial temporal lobe at the junction of the lingual gyrus and the fusiform gyrus. This led us to plan the formulation was a right posterior temporal lobe epilepsy, and so we planned an SEEG targeting that areas with particular focus on the lingual gyrus and the fusiform. And essentially, this cartoon just summarizes a long story short. Seizure onset was seen in fusiform, right fusiform, and lingual gyri, shown here on the axial and the sagittal. And if we make a recon of this, here's the side view, of course, with the surface vasculature and the SEEG electrodes. Here's the SEEG electrodes with the surface made transparent, and you'll see in red those contacts involved in seizure onset in the fusiform and lingual gyri. And here we've superimposed the optic radiation and the optic cortex. Now, the issue, of course, is that a conventional surgery would have caused a hemianopia, as the surgical approach would have to pass through the optic radiation to access the fusiform and lingual gyri. So we considered that wasn't a good outcome for this young lady, and were able to design a LITT trajectory running from posterior to anterior along the lingual and the fusiform gyri, but remaining medial and inferior to the optic radiation. So this was done, and this is the site of the catheter, and this was the ablation abutting the tentorium cerebelli and remaining nicely medial to the optic radiation. So the conclusion, the outcome of this is that she was seizure-free for about 4 months. She then decided to stop taking all her medications rather abruptly at a couple of seizures, and is now back on a small dose of a single anti-seizure medication. There is no visual field defect and in fact, no deficit at all. So I think we can conclude from this that LITT is certainly less invasive than conventional neurosurgery. There's quicker recovery. There's less collateral damage along the access pathway. We've discussed the role of this in hippocampal sclerosis with lower seizure freedom rate, but also less cognitive deficits. And I've illustrated to you how one can use a LITT as a suitable treatment for some near cortical temporal lobe epilepsies. And thank you for your attention.
Well, thank you. Thank you for this wonderful talk and this nice example of where to use LITT in this clinical case. I have some questions about this, and one of them is for the reduced surgery. When we know that we have a more risky surgery after the LITT procedure, so do you think that if we do once the LITT for hippocampal sclerosis and the patient still has seizures, we should go for another LITT or an open surgery?
Yeah, I think a second lit certainly feasible. I think it depends a little bit on what area has been ablated. I mean, so
Yeah.
for example, if the ablation took out the anterior 50% of hippocampus and part of the amygdala, but the piriform cortex was left in situ and connected, one could perhaps design a second trajectory to target the piriform.
Okay, so what I think the beauty of the LIT is that before we were arguing against for the anterior temporal lobectomy or selective procedure. So we were arguing this, which was the best procedure to do. And now we have a super selective procedure that is LIT. So probably we don't need to do anterior temporal lobectomy for a simple mesial temporal epilepsy, and so we should go more selective even in surgery. Or what do you think about this? So
Well,
do
I
you
think,
think that
clearly the attraction of LIT is that you avoid the collateral damage
yeah
of getting to the part of the brain that you want to actually resect. I mean, we get much less damage to, particularly to white matter tracts like IFOF, arcuate, and also much less, one gets less damage to the lateral temporal neocortex, even if it's a fairly restricted corticectomy with taking out the temporal pole and then going medially. There's still more collateral damage from the access needed. So I think that's certainly an advantage from LIT. I think one can't get away, though, from the fact that the seizure freedom rate is less good. And I think often it's, I think, down to patient choice, really. I mean, if
yeah
somebody's very highly functioning, let's say if somebody is a lawyer and they have to have a very quick, good word finding and very good verbal memory to function well at their job, for them, LIT is probably a very attractive first option. If, however, somebody does not function at such a demanding intellectual and cognitive level, and their aspiration is to be free of seizures so they can drive, then their choice for them might be to go for perhaps a more definitive conventional surgical approach.
Could I ask a
okay
question?
yes please
Because I have this exact example is a patient of mine, is a lawyer, and well, we proposed a LIT to her, but in that case, can you be sure that you will not have memory problems or any verbal
No, you can't be
issues?
sure. I mean, I think the
Yes.
data. I think Dr. Drain's data is probably the most robust. What's it? 10% of people had significant verbal memory decline. So the risk is not zero.
No, and that's on average. That's the main
Yeah.
problem that I have, that it's very difficult to, well, anyways. I have another question. Well, there's another question in the chat, which is
yeah
also
we can.
related to this one. It's whether you would recommend LIT for hippocampal sclerosis in an elderly patient, well, the elderly is 59 years old, on the dominant hemisphere with cognitive dysfunction, let's say.
I think in that situation where the cognitive state is more fragile, that becomes a more attractive option, I must say.
And do you also consider it on the right-hand side, or do you make any distinction between left and right? Well, dominant versus non-dominant.
I think the dominant temporal lobe is more fragile. There's more one can do, certainly cause more harm there, but not to say that the right temporal lobe is a free fire zone, as it were. Certainly, you may get some actually language difficulties from a non-dominant temporal lobe resection. You may certainly get some memory deficits that may be obviously visual, but also there may be some verbal memory deficits. I mean, I think often we don't ask the right questions. I think I can certainly think of people. I mean, the two patients actually can really come to mind. A lady in her late 60s who had troublesome temporal lobe epilepsy, and we assured her it was non-dominant. We kind of assured her that there shouldn't be a bad memory deficit. She came back to clinic for follow-up in a really angry state because nobody had told her that she wouldn't be able to remember knitting patterns. Knitting was her big passion. And she found that her ability
Okay.
to remember knitting patterns was markedly compromised. And she was really, really cross about this. So I think that was a real example where we didn't ask the right questions and we didn't understand her fragility beforehand. I think the other profession for whom this can be a big problem is somebody who is an architect, who does a lot of computer aided design, or indeed other designers who need a lot of good 3D memory. So I think one has to understand that there's more to cognition than just brute verbal memory. And we really have to modulate our advice according to the individual person. And of course, generally, if somebody is fragile, and by fragile, they may be fragile because of comorbidities, but also a bit like an Olympic athlete. If somebody's functioning at a very high level, they're very fragile. And even a few points off their performance may have a career-changing effect. Whereas if somebody, digs holes in the road for a living, they're much more robust in terms of much less likely to cause them harm.
Okay.
Also, two
And
questions when possible.
Yeah.
So,
please.
we all face in all countries in the world the large treatment gap between the procedure and the surgery. What about this famous paper of Stéphane Chabardes, the role of the temporal pole? So when you think you have a mesial temporal focus, you do a selective procedure, but people forget the temporal pole. So that's also a reason that many people take out the temporal pole or in an anterior temporal lobectomy. What is your strategy when you see a kind of hippocampal sclerosis? You say, okay, that must be the seizure onset zone. Let's do a LITT. Or do you do electrode implantation before, just to be sure that there is no other seizure onset zone in the temporal lobe?
I must say we wouldn't, if it looked like clear-cut mesiotemporal lobe epilepsy without any with no clear-cut imaging abnormalities, concordant scalp recordings, we would not generally subject that person to SEEG. We would make a decision, I think, on the best surgical approach. And in general, actually, I've been surprised when we go through this with people, a surprising number of people make their mind up as to what they want. Relatively few patients, I try and put the choices before people with some degree of equipoise. Well, there's this and there's that, and there's different risks and different benefits from the two approaches, be it LITT or in our surgical anterior temporal lobe resections that Anna Mizrachi and Andrew McAvoy do here. It is a polectomy, if you like, and the corticectomy is very anterior and inferior because we visualize the optic radiation with tractography, and the surgery is designed to avoid Mayer's loop. So indeed, our visual field deficit is down from what used to be 20% to about 3% now. So it's a pretty minimal or minimized, let me say, cortical resection. But I think patients will often say, you give them the option and they've made their mind up already. This is what they want. And we certainly have people say, I only want LITT. Other people say, I only want to go for the definitive solution. Please do it and fix this and give me the highest possible chance that this problem is behind me.
Yeah.
And I think we weren't part of the SLATE study, but my understanding that was one of the big issues with recruitment to that is that many people had made up their mind as to what approach they wanted, and not so many had equipoise.
Right.
Okay.
And the last one, that's a very short one. So that is, I think many in the audience perhaps are also from the ELMIC countries. So what about the economic things, the economic evaluation? So I can imagine the UK healthcare system is quite the same as in the Netherlands. And well, we say it's not only effectiveness we also have to prove cost effectiveness.
For sure.
And that's in every country, of course, because of the financial system difference. But how do you look at this point in your opinion? So in the UK, or also what would be your advice to people in ELMIC countries when you hear?
Yeah, we have very rigorous cost effectiveness evaluations for any new therapy in terms of quality years and so on. And the argument, the key argument was time to return to work. In that if you are in the hospital for 4 days, and you're not productive economically for 2 months, that's a big cost. Whereas if you're back at work within a week, and that now the argument we had to make is that many health service finance managers almost said, not quite, but they implied that they didn't really care about that money because that wasn't health service money. That was a different pot. So you had to say, look, guys, you need to take a broader view of the cost to society, and that if a person can go back to work and pay their taxes and pay for their family and everything, and not be dependent on benefits or handouts or other people not working to care for these people, that's good for the societal spend. And there's a lot of debate to and back and forth, and at the end of the day, we won the argument that actually, although you spend 10,000 euros on a catheter, the hospital stay, firstly, is shorter. It's only 24 hours rather than, well, and 4 days would be the norm for a temporal lobe resection, staying in the hospital. That, of course, saves a lot of money, but it's the out of hospital costs is considerable.
Okay. Just one last question about the reduced surgery. If you have to do an open resection after laser ablation, do you know which is the best timing to do it right away, or maybe later, to wait some months? I don't know.
Well, I think in general, one would always want to probably leave it a year.
Okay.
Because one doesn't, we're all familiar with the running down phenomenon, where somebody may have seizures in the first couple of months, and then it gradually fades out. So I would never say never, but apart from that, I wouldn't advocate doing an early second procedure early on, because it may be that actually with a bit of time and the patience that things actually will resolve over that time.
Okay, and maybe I can do the same question to Dan Curry about if a patient of yours after an ablation of hamartoma has a seizure, gelastic seizure 1 week after or 2 weeks after. Do you think it's a failure, or maybe you will wait some more weeks or months until you declare it as a failure?
Yeah, we always wait. The running down phenomenon is pretty clear, and it's especially prevalent in these HH kids with 20 seizures a day. So my rule of thumb, and certainly isn't proven by anyone, is if there's anything different about that seizure behavior, is it less frequent? Is it less? Is it more brief? Are the clusters more brief? Things like that. Is the manifestation a little bit different? That's a good sign, because I've disturbed the network and the network needs some settling down. If it's exactly the same, of course, most families aren't going to tell you that precisely, but if it's exactly the same, it's usually disappointing. And a year later, 9 months later, we're going after the other part.
Okay. Thank you very much. So finally, Professor Carl Rössler from the Medical University of Vienna will explore the current and future role of LITT in Europe, comparing developments and adoption of the technique with US and Canada.
Yeah, thank you very much for the introduction and for the invitation. Thank you for having me. My talk for today is a little bit philosophical, but only at the end. I will start with a technical description, how we do LITT surgery in Vienna at our department. I will then tell you about our patients we have done the last few years, focusing on tuberous sclerosis children with intractable epilepsy. And then I have some data in the literature review about comparing usage and different aspects of LITT in Europe compared to USA and Canada. I have no scientific or financial conflict of interests. As we talk about a minimal invasive topic today, I just want to remember you with my first slide that minimal invasive epilepsy surgery and more invasive or a minimal invasive open epilepsy surgery is a parallel development. So Victor Horsley is referred to has done his first epilepsy surgery 140 years ago, but at the same time he developed the first stereotactic frame for monkeys because he was investigating structural and electrophysiological issues in monkeys' cerebellum. What we are dealing with in modern epilepsy surgery are minimally invasive approaches. So this also includes the resective surgery approaches, of course, the minimal invasive diagnostic procedures, disconnective surgeries, and of course we are talking about LITT, the minimal invasive ablative procedure, but also not to forget the stimulation procedures. We have heard already about the technical issues. We in Vienna use the Medtronic Visualize system. In Europe, it's the only available system. And what we use, how we apply the LITT fibers in our department has developed since we have got installed an intraoperative two-room MRI concept in October 2020. It's a surgical operating theater which is separated by a sliding door from the sterile MRI room, which is equipped in our department with a 3 Tesla system. And we use this environment also for our LITT procedures, which means we position the patient on this operating table and have the head pinned in the so-called Nora's head clamp. It is the coil for the MRI investigation, but it's also a kind of stereotactic frame. And before starting the procedure, we are performing the first scanning in the MR room. And with these scans, they are fused with the planning, and the head is automatically detected by a frameless system. And we can use either a mini robot for positioning the fibers, or use an articulated arm. We did all our procedures frameless, which was, I think, which we have also documented that it was very accurate because of this frame coil system. So this is the sliding carbon fiber table part of the operating table, which is slided on a transport trolley. And after having placed the LITT fibers, we can roll the patient into the MRI and doing the ablation procedure. This saves us a lot of time at one hand, but also it is more convenient for the patient, because if you have to transport the patient through floors from the OR to the MRI, there may be some issues with LITT placement, and you might lose some accuracy. So we started our first LITT procedure with a tuberous sclerosis kit. This was also referred to from Dan, who did this paper in 2012, where he basically described these 4 or 5 main indications for LITT ablations. And he had also, I think, 2 tuberous sclerosis kits. In this kit was a 6-year-old girl She had her first seizure with 4 months. When we saw her at the age of 6, she had a right-sided hemiparesis, delayed development, had no speech, was autoaggressive, and couldn't walk alone. It was genetically verified, and the phase 1 EEG pointed to the left hemisphere, where we performed the stereo EEG, and we had 2 tuber complexes which fired, and this was the stereo EEG, and we planned both sides with 2 fibers. This one was precentrally very next to the motor cortex, and the second one was near Wernicke's speech area. The second one was done 3 months later. It was a staged procedure, and what we saw was a dramatically improvement of the EEG, and she stayed altogether 6 months completely seizure-free, had a steep progress in speech and motor function, and was the first time ambulatory by herself. So we thought we would do this kind of treatments for the TSC patients, but not without SEG. We used in every case SEG for defining the most epileptogenic tuber, and did LITT after that. As for LITT, TSC surgery is a very established kind of epilepsy surgery. There are numerous papers, and it's really a good thing, with seizure freedom rates of 64% with resections. I will give you an example for such a resection. This was a very young child, 2 months old. She had this temporal tuber. We resected this using all our fancy stuff, intraoperative EEG and augmented reality guidance. And here you can see the tuber and the contour planning for resection. The child got seizure-free, but the problem in the small child is the chance to get a complication is very high. And this child, she developed a refractory hygroma. We had to put in a subdural peritoneal shunt, and she spent a few times in the hospital. So that we were very happy to have changed to this concept of MRG-guided LITT for these kind of patients, where we don't have to resect so often and have complications. So these are our LITT cases since we started. And what you see is 8 cases are tuberous sclerosis kids. 3 kids have had focal cortical dysplasias, sporadic ones. And we had 2 adults, one with subependymal nodular heterotopia and one with an MRI negative temporal lobe epilepsy. So in the 3 focal cortical dysplasias, we were quite successfully. 2 are staying seizure-free since the surgery, and there are 2 years of follow-up now. In the 8 TSC children, we have 2 who are still seizure-free, 25%. The others developed seizures in different intervals, 3 to 6 months to 1 year, and 2 had open surgeries. The third part of my talk is a kind of literature review and interpretation about the differences between LITT in Europe and the United States and Canada. And for that, I interviewed a company, our distributor from the company, and he gave me these numbers. So worldwide, it's only for Medtronic visualized centers. Worldwide, there are about more than 200 visualized centers, and 150 are in the United States, and about 60 are in Europe. And globally per year, there are done about 1,400 LITT procedures, about half of them in tumor cases and half of them in epilepsy cases. And if you look in Europe, there are about 260 cases, and there are far more epilepsy cases than tumor cases. There also have been done a few tremor cases. And if you analyze numbers of treatments and numbers of residents of Europe compared to US, you will see that in Europe you have one center for about 13 million residents, yeah, with 750 million residents altogether. And in the US, you have about one center for 2.3 millions. And this gives a caseload of about 3 cases per year per million residents in the US, and a tenth of that, which means 0.3 cases per year per million in Europe. So this is mainly the difference, the numbers in difference. What is also discussed heavily in the literature is about the costs. LITT patients, obviously, they have shorter lengths of stay. This saves a lot of costs. The complication rate is reported lower in this database, US database, of about 6,000 patients. You have not that much difference in complications, 2% versus 3% open versus LITT surgery. And you have lower mean costs per procedure, which means LITT procedure, you have about $140,000, and the open surgery is $230,000. But in this paper, also US paper, one point is discussed. It's the fact that we have to estimate the costs not per procedure, but per seizure-free patient, in fact. And what they did a prospective study, 40 LITT procedures, 40 anterotemporal lobe resections. They found a huge difference in seizure outcome. It's not that much if you do a meta-analysis, but what they had about 1/3 of the LITT patients had to undergo a subsequent anterotemporal lobe resection. And if you now look at the cost from this standpoint, you have about $100,000 for the anterotemporal lobe resection per seizure-free patient. If you have LITT with subsequent anterotemporal lobe resection, your costs double. And if you count all LITT procedures on LITT seizure-free patients, you have about $300,000 for a LITT seizure-free patient. So with complications, this is also from the US, systematic review of the literature, relatively recent. And what you have a relatively high rate of technical complications, 18%. They found neurological complications in about 16% of patients, cognitive disturbances, 16% of patients, hemorrhage rate about 7%. And if you compare that with the classical open surgery complication series of Behrens and Schramm, they had about 5% neurological complications and altogether 13% surgical complications. What we also see in the literature of US papers like these national-wide sample-based propensity score matched analysis, we see that these were 128,000 patients. We see LITT goes up, obviously, and VNS goes down. So it seems that LITT has something to do with substituting indications for VNS. But what we also see in this analysis in this paper is that there are still 95% of all surgical procedures in these epilepsy patients were open surgical procedures, and only 5% were LITT procedures. So this is the literature review from John's group. And maybe it's a kind of European view on LITT. There is the statement of less efficacious than open surgery. And there is referred anterotemporal lobe resection still as the gold standard with 72% estimated seizure-free rate person years. What we should not forget is gamma knife for this indication. And the LITT procedure is significantly inferior. If you look at the US centers view in this paper, it's a multi-center cohort study, result of a multi-center cohort study. You estimate, you recognize the statement MRG LITT is a minimally invasive first-line surgical treatment with durable outcomes for selected patients with drug-resistant mesial temporal lobe epilepsy, and anterotemporal lobectomy remains a treatment option for those with persistent seizures after LITT. So maybe the difference between Europe and United States is that in Europe, maybe anterotemporal lobectomy or anteromesial temporal lobectomy, which means pole plus mesial structures, or selective amygdala hippocampectomy is still the gold standard. And maybe in the United States, the gold standard is already LITT for temporal lobe epilepsy. And what is important to state is that this is meant for mesial temporal lobe epilepsy, like hippocampal sclerosis, like this systematic review meta-analysis shows very clearly that in mesial temporal lobe epilepsy, you have success rates of up to 55%, but in lateral temporal lobe epilepsy, you have still only 30% success rate. And concerning the cognitive outcome, I think there is still no randomized prospective trial which should investigate this topic, because if you look at the US papers, you recognize that the LITT procedures are mainly done in highly specialized centers. There are more or even significant more patients with private insurance, which means that they are very high functioning patients, and maybe this could lead to a bias. So as already discussed, salvage surgery is an option for LITT, but also a second LITT, of course. I can recommend you this review. It's from 2025. And you see, if you have a failed LITT patients, you can do SEG again, or you can, if you are sure that the seizure still comes from the already treated location, you can repeat the LITT or you can resect. And I will give you an example for such a failed LITT surgery which we had in a tuberous sclerosis child. She was 3 years old when we saw her for a LITT for this firing right temporal tuber. We had confirmed the right temporal epileptogenesis by SEG, and we did the tuber and the mesial structures, did the ablation, and she got seizure-free. Seizures came back 9 months later. We did a SEG again, and we saw the seizures coming again from the right temporal lobe. And then I did a right temporal lobectomy. And this I can confirm or confess was the worst temporal mesial resection I ever did. Here you can see the scar tissue of the hippocampus and parahippocampal gyrus. Here the midbrain comes into sight. And here I'm pulling up the scar tissue from the posterior cerebral artery. And this is the mesencephalon. So it was really dangerous. It all went well, but I wouldn't like to do such surgery again. So as a conclusion, I personally don't know where we are with LITT on this Gardner hype cycle. Of course, there is a difference between Europe and US, Canada, and maybe this could be a point for the following discussion. Thank you very much.
Well, thank you. Wonderful talk and a lot to discuss. Maybe we can open for Daniel Curry to comment. Maybe he has a different view than us from Europe.
No, that was a great review. Thank you, Carl. The point he makes about the less invasive approach in these children, especially with TSC, is very important. And I currently have a child on my service who had multiple operations for TSC and has bilateral big subdurals, and we're still having seizures. So we're going through the precarious process of stereo EEG through the subdural and into the brain. It's a mess. So, and the number of complications you can run into are nearly endless in that scenario. So the more we can keep everything intact, the better the outcomes on those large cranial cerebral disproportion kids, where things are going to move around. The adult world is an interesting challenge. I think the financial issues are very, very important and are likely going to be a bigger influence than anything on this. I think a lot of the temporal lobe approaches, at least the Columbia group that you referenced there, they did show that, especially in non-MTS kids or patients, augmenting with stereo EEG is very important. But I think we're going to come down to a size problem. LITT just can't do what, the open surgery can. And it could, or at least get closer to it if you use multiple catheters, but as financially inhibiting. And I think that's on the company, because I just can't imagine that little piece of plastic that I'm using is $8,000 or is $8,000 to $10,000 a piece. Clearly, there is some room for adjustment of these that are making it difficult for us as ablaters to match some of the outcomes in the open surgical world through a minimally invasive approach. But I don't know when they're going to come around to that. I'm no financier by any stretch.
Thank you, Ben. Thank you for your comments. Are there any other questions or comments from the panel? We only have one question from Dirk van Roos, but it was for Professor Duncan, and he's no longer here. So maybe we can answer him later on. I have a question. When you are doing SEG in TSC patients, do you try to do radio frequency to like a surrogate for a good outcome if you do a laser ablation, or you don't think it's important because it's too big to do radio frequency ablation?
So at the moment we are using the ETEC electrode, so it's not possible to do thermocoagulation with these electrodes. And additionally, I think the lesion volume is much too small to have any impact on these mostly very large tubers. So it's also in these tubers normally one fiber is not enough. So you need sometimes 2 or 3 fibers to ablate the tuber.
Okay.
So question for you, Carl. So the many people at this moment say the tubers themselves are epileptogenic. So the seizure onset zone is the tuber. But there are also colleagues, they say, well, the perilesional cortex is also a cause in this disease. So how do you say that? Because you implant the ETEC electrodes, what did you see in your series? Is it the tuber itself, or is it the perilesional cortex, or how was this proportion? Do you know that? Carl's is
think he's frozen. So maybe a connection problem. We'll wait a little bit if Carl comes back.
Well, maybe to comment on this, I was just assuming these were type 2 dysplasias, no? And I never thought about considering them as other entities. What do you think about this, Alexander?
Well, we are not doing LITT for TSC until now. So we are just removing the largest tubers that are responsible for the seizures. We implant them with the SEEG. Usually we try to do radio frequency ablation, even if it's just a small part of the tuber, and try to understand if it makes some impact on the seizure frequency, and usually it does, even if it's a small lesion, and it's a much smaller lesion than the laser. But then we remove it. We don't use LITT. We didn't use the LITT until now for tuberous sclerosis. So Carl is back.
Sorry, I had a connection problem.
Okay. Did you have you heard Olaf's question or no?
Oh,
So
only
please,
partly.
Olaf.
Only partly.
Okay.
Olaf, can you repeat, please?
Sure. I just wanted to ask you, Carl, the tuber themselves are epileptogenic, but there are also groups, they say the perilesional cortex is the problem. So do you know the ratio, the proportion in your series, because you implanted with ETEC electrodes, what was the problem, the tuber itself or the perilesional cortex, and how did you deal with that?
In most of the cases, it was perilesional. We normally have electrodes in the tuber, but we also have electrodes around the tuber. And what we saw in these cases is that the electrodes around, they had more epileptogenicity than the tuber electrodes.
Okay, so that's quite interesting because Tom also commented that, well, in the tuber you have the balloon cells and the dyslaminated cortex, like in the FCD type 2B, but still you see more activity in the perilesional area.
Yeah, yeah.
Okay. We have two questions. One is, how does the TS tissue react to heat, and can you achieve maximal destruction as seen in other lesions? So when you plan your destruction, do you think it's different from other kind of lesions like hippocampal sclerosis or an FCD or something?
Yeah, it's much different. You need more energy, much more energy.
Okay.
I can't tell the numbers, but
And so, and you plan the fiber to go inside the tuber, and then you extend the heat destruction to the surrounding tissue, is it?
Yeah, exactly.
Okay. Okay. And a question from Dirk van Roost. Is everolimus administration tried in tuberous sclerosis cases prior to considering resection or LITT ablation?
Yeah, in every case, all kids get all kind of medications, including everolimus.
Yeah, I guess. We also are trying everolimus in our cases. And again, from Yugoslav, so how big is the lesion? So I think it means where is your extent over the lesion for your planning of your ablation?
Maybe I should go on the slide, back on the slides. We calculated every lesion volume, but you can think about how many LITT fibers you will use to cover all these volume. So you know your volume of what you can do with one LITT fiber, and you can calculate how many fibers you need to lesion the tuber. But normally we didn't use more than 3 fibers because we are afraid that we get a too large necrotic volume with maybe not controllable edema formation. And we never did give the dexamethasone before. We only started in the morning of the procedure to start with dexamethasone. But of course, it's not a so delicate surgery than hypothalamic hematomas.
Can I ask Daniel Curry about this? So is the volume concern for you in these lateral lesions, not hematomas now?
We haven't had a problem with volume and mass effect. Two worries about the steroids. True, it's not the sort of thing we do in TS very commonly. We do it in more of a reactive way. If we get edema that is symptomatic, and one of the main reasons is in the EMU, some of these children, steroids is a treatment. Steroids is an anti-epileptic. So when you have the electrodes in, you want them to have seizures. If you give them preoperative steroids or the presumptive steroids a week ago or a week prior, you're going to reduce the number of seizures you're going to be able to identify. So it really is a problem. The younger you go. So there's this anti-epileptic effect that complicates our localization. So we mainly do it as a reaction. And the main times in which that occurs is usually if I'm ablating the insula. Posterior limb of the internal capsule is close, and that helps. The steroids help there.
There is one more question from the Q&A box. How many fibers do you usually use for mesial sclerosis? I don't know, Carl. Have you experience with this?
We didn't do any temporal lobe epilepsy case, only the girl with the tuber. There we used 1 fiber for the hippocampus.
Yes, we only have one case of hippocampus sclerosis, and we also used one fiber. And John Duncan is no longer here. So, okay, is there any other questions? Otherwise, I think I have to thank you all. It was a wonderful session. Thank you, Daniel Curry, Carl Russo, and John Duncan for this wonderful webinar. And okay, I hope you see each other soon in person.
Yeah, thank you very much for your
Bye-bye.
nice comments.
Thank you so much.
Thank you very much. Thank you.